We're going to talk metastatic cancer now, guys, and I want to start the discussion, and Herb, let me let you take the lead on this. Okay, evolution of RAS testing. So, you know, it was EGFR receptors, RAS. Tell us about that. Where are we today? And I think really importantly, and I'm going to reach out to each of you, how are you getting this done? It was a year of evolution of changing the rules, if you will, on testing. So you give us, again, the overview of RAS testing today, and then we'll talk about various ways of doing that testing.
Right. So RAS testing is necessary in order to make the decision about whether or not to give an anti-EGFR antibody, whether it's cetuximab or panitumumab. The biggest issue is whether you want to give that anti-EGFR therapy first line or in a later line, because that drives how quickly you need to rush to do the test. The next issue is whether you're going to use the sort of so-called exon 2 KRAS, codon 1213 standard RAS testing, or to get the so-called extended RAS, which also includes exons 3 and 4 in KRAS and the 2, 3, and 4 exons in NRAS. And that gives you about 15% of extra patients. The standard test is the sort of the current workhorse, what's sort of the FDA approved, but I think extended RAS is probably appropriate. The challenge is the turnaround time on these tests to make a treatment decision and how long the patient can wait. This gets to be a much longer discussion than around availability of tests, and particularly preference in sequencing drugs, both chemotherapy and targeted therapies, which you probably want to include everybody else on.
So we did this same conversation a year ago, and yet I am still seeing regular, good community docs not doing this. Where are we falling short? How do we help them? Yeah. Axel, give us some insights.
So I think we need to be more dogmatic. Because even Herb left to me might be whatever, a standard workhorse, whatever. The workhorse we need to implement right now is extended RAS testing. We should not sway away. NCCN guidelines have embraced it. The Europeans have done it for a year and a half. It is part of package insert.
Well, it's label change now here in the States.
Axel, do you think the recent JCO editorial on this went far enough at being dogmatic? I thought it was not a little wussy.
Yeah, I think, in the end, when we are talking about 15% of patients with KRAS wild-type tumors, 1 out of 6 patients sitting in front of you, when you get treatment with cetuximab, panitumumab, depending on the backbone, you clearly have no benefit.
So has everyone had patients like this? I just want to be clear. Me too. I mean, you see them all the time, right? Yeah. It's not like a rare thing.
And it depends on backbone. You might even have a detriment based on the data we see from panitumumab, FOLFOX. I mean, when we talk about patient safety, we talk about pharmacoeconomics, everything screams we cannot just use the old workhorse. We need to be dogmatic. This is standard of care.
But we had just taught all these people how to do KRAS, and then we changed the rules.
But
we
that's easy
it on
because
them.
If you use the new next generation tests that are out there right now, turnaround time is 12 work days. That's what it is. The European guidelines mandate turnaround time for comprehensive RAS testing for 7 work days.
So having solicited the comments and controversies for JCO, remember, all expanded RAS is not covered by insurers at this point.
It's actually, we've never had a problem
but theoretically, and it's not.
They could pull back. They could pull back.
But they won't.
And I think there's subtleties here, which is to say that these are rare mutations. And in fact, we don't know that each individual mutation does connote the poor prognosis.
The same way.
Almost certainly they do. But we don't know the driving power of each of these mutations. Having said that, we do it, we routinely do it, and we have our own in-house assay that we do it with. And our turnaround time is 8 days, actually. So I think we need to get there, but in fact, it's, I think we also need to get BRAF testing as a routine, which we try to do as well.
But most people out there do not have this in-house. So,
But there are labs available commercial labs
can do it.
So can I give an advertisement? One of my current jobs is editor of ASCO University. And we have tumor boards, and we just instituted a molecular oncology tumor board. So Stan Hamilton, Len Saltz wrote the case. Stan Hamilton provided the data on extended RAS testing. It's online. It went online yesterday to coincide with the beginning of this meeting. And so far there have been 800 comments And what's going to happen is over a 2-week period of time, people will be able to comment on what they're doing, what they see the problems are they able to get the testing? Because I think there's a certain people that can get it. Right. In our institutions, we get it. And in other places, they're not getting it, either because they don't know they can get it or they think there's insurance problems. And I think there's an educational gap.
Yeah. So how do we bridge this? How do we, because at our shop, for example, we, the oncologists, needed to meet with the pathologist and say this needs to change, because it wasn't in their literature, it's in our literature. And then they're worried about reimbursement and all of this, and companies are springing up. Is there a strategy? What are you guys doing in Durham?
There are other issues, including compliance of doing, testing and billing for it from the pathology group that's beyond just the economics. There's a compliance aspect at their end. That said, to Axel's point, we all have to organize and get beyond this. It is state of the art. There's the potential for harm. It's not that hard. And I think this is like several years ago, we had to organize how to get RAS, just simple RAS done. And that took forever and was like pulling teeth. We have to move on and get this done. The biggest issue is in sort of when this gets done is whether or not other mutations get done in these so-called multi-hotspot testing, and then what to do with the extra cost or information that comes with that that's far less useful.
So that simplifies testing if you just send off and get everything. You get MSI, you get RAS, BRAF, we'll talk about it.
It actually complicates.
But it also gives you other stuff that may be noise. BRAF, Axel, what are you doing?
So we test it routinely. It's a prognostic marker, a highly prognostic
So do you then
marker.
get this test back and say you're in trouble?
No. So number one, there are trials out there. The Intergroup has just launched a large trial which is accessible virtually to everyone. The other point is, there are data actually coming from an Italian group that those aggressive tumors might benefit from more aggressive therapy. Similar to what we did in pancreas cancer, when for a long time we made the mistake, aggressive tumor, we give a little gemcitabine, and it doesn't help, but it doesn't harm. Then we used FOLFIRINOX, and all of a sudden things turn around. We see a lot more responses. BRAF mutant tumors, aggressive cancers, and those patients need more aggressive therapy. If patients can tolerate. FOLFIRINOX-Bev, New England Journal paper from our colleagues in Italy, they showed, at least in actually the third report, again, small subsets of patients, but that the triplet combination plus bevacizumab actually is quite active.
Yeah. But to this point, there's a certain ethical component to this. Is when you're talking to your patients and you get the BRAF mutation back, do you have a real serious discussion? You mentioned that, is to sit down and say, oh, okay, I've been reading that the average, from newer studies, the average survival now is 28 to 30 months. It's 10 months for these folks.
So what we do is we talk about
sequential therapy is not an issue. It's one therapy, maybe.
Well, it's not clear. Or what we talk about is what we're getting in line to do the next treatment. For example, if many times they've already started their first line therapy, so we will get them queued up for the intergroup study or a study we're doing in-house, because it's actually not clear that they do all that much worse on the first line. It's very clear that they don't do very well on subsequent lines.
Yeah, and they have once they progress rapidly, and then you have no chance to catch up. That's really, but coming back to, not communicating a strong prognostic factor to a patient. Okay, if you have a patient with massive liver involvement and lung involvement, these patients are in a bad spot too. You communicate that too, because these patients need to know. Now we're moving this from a CT scan bad prognosis marker to a molecular marker, and I think patients have the right to know. And now it's similar to when I talk to my patient and say, do you want to see your scan? And actually 95% say yes, but 5% say no. So, okay, so you want to know your BRAF status. Yeah, yes or no. So I think we have ways to communicate that.
And it's also, I should go back to the genetic testing, by the way. Many people remain hesitant to do anything genetic. For whatever the fear is. They don't want to know, they're afraid of their insurance. So as we go back and we think about, that's also a complex discussion with patients who may not reflect to be willing to do that.
Before leaving, go ahead, sir.
One of the issues that Stan Hamilton is going to be discussing is the issue of getting back these other mutations where you're not sure they're actionable, and how much you talk to a patient about an APC mutation, for example, because you don't know what it means. Yeah. Do you discuss that with the patient or not? Yeah.
All right, so before moving off of RAS, do you all do you want to know before you start or can you start and get the test? Excellent.
So number one,
And
RAS.
we'll come back to the studies,
Okay,
but just what your
yeah.
policy is on RAS testing
If
and
we
what
see
you,
a patient up front, we get comprehensive RAS testing and BRAF up front, with the idea that, you know, even if you don't use EGF receptor antibodies first line, the result stays consistent. I mean, there's clear data that RAS does not necessarily change unless you give EGF receptor antibody therapy, which might turn wild-type RAS to mutant RAS, but that's a different issue.
policy?
Needs to be done, try to hustle. On the other hand, my default, the discussion with the patient about what to do first line usually defaults to chemo plus Bev, not an EGFR antibody first line. I think there's equipoise related to the two options, but there's usually a slight preference based on toxicity and tolerability. So I try to push, but I also don't get in a tizzy, if it takes an extra week to come back.